Le doy la bienvenida al doctor Friederich. Él es profesor actualmente de la Universidad de Basel. Él se formó como médico en la Universidad de Berman de Suiza, se certificó como médico ortopedista. Posteriormente, él ha formado parte de diversos puestos académicos y de dirección en la Universidad de Basel y también ha escrito diversas publicaciones, tiene una cantidad inimaginable de publicaciones sobre artroscopía, sobre también técnicas relevantes en técnicas quirúrgicas para manejo de rodilla. Él es parte y forma parte de la Sociedad Internacional de Artroscopía y Cirugía de Rodilla y de Medicina del Deporte, la denominada ISACOS. Él también asesora parte de otras clínicas de artroscopía privadas y de Suiza. Entonces, pues realmente su experiencia es muy amplia en este campo de la ortopedia. Le doy la bienvenida al doctor Friederich. Le agradezco mucho su tiempo aquí y que comparta su experiencia y que ahora sí que nos enamore de la ortopedia.
Gracias. Gracias, Muta. Parlo italiano, ma non hablo Spanish. So I will speak in English. I will speak slowly. I would like to thank the translators. They did a tremendous job. Thank you. Because Gloria was speaking very fast, and I got everything translated. Muchas gracias. I'm an orthopedic surgeon. You all have been sitting now for 45 minutes. And I would say, stand up, stretch, get yourself a bit motion, and then we go into my talk, okay?
It's a little loud. Thank you.
It's a long way from Switzerland to Mexico, so there's some saludos, and I brought something to you which you will need, some fresh air. Okay. This is the view from my little cabin in the mountains. When I open the window in the morning, there's fresh air. There's also some saludos de Basilea. This is a small university center. The surroundings of Basel is 500,000 people, only 500,000. It's not much. I have some disclosures, and I usually put it up more than just a fifth of a second, so you can see what's all about. Thank you for the introduction, and as you see, I do some consulting for the Deutsche Arthrosehilfe. This is a huge German organization looking at, arthritis. I have done some consulting with Virchamed and Medical Insights. Basel is small, but we are living at the edge of 3 countries. And that's why I would like to show you something. This is not virtual reality, this is reality. Okay. This is the lookout of my office. When I look to the left side, I see Novartis campus, I see France. By the way, the parking lot of Novartis is in France. So you park your car in France and you walk over to the office, which is in Switzerland. Novartis is a huge company, and when I look out of my window to the right, I see the Roche Tower, and again, Germany. And we are a small country. There's not enough space for the airport. So the Basel airport is in France. We rented the property, the government did, for 99 years from the French government. However, when the French air controllers are on strike, the airport is closed. If the air is bad in Mexico City, the schools are closed. So we live with those closure, okay? When I talk to my trainees, we are like pilots. Pilots are special. They have very standardized learning. And nobody wants them to crash. You don't want to have a crash when you're sitting in a plane. In orthopedics or in surgery, it's a little bit different. We are not that standardized. Every teacher, every professor has his way to teach. And he thinks his way is correct, the other one not. It's part of life in surgery. And then they say and claim every patient is different. Why should you use simulation? Okay. I wrote this paper. It's called Simsalabim, according to the code word used by magicians, Ali Simsalabim. And I wrote that, and I wanted just to say, it's not just Simsalabim. You just buy some simulators and you're all done. You heard from Gloria Salazar, the debriefing is important. And the debriefing is not made by a machine. It's done by you, by all of you, you teachers. You are going to be the icing on the cake in simulation. We have a change of paradigm in teaching, of course. I remember when I learned arthroscopy, the head of the department would let me have a look, maybe half a minute, maybe 10 seconds, just to have a look because there was no camera. He would sort of put it on and I had to look in. That changed a lot. And simulation has come a long way. I show you here the Solomon Islands. As you've seen on my disclosures, I teach also in the Pacific Island. So what I did, I took the simulator to this low and middle income country to teach the trainees. It should be working. Yeah. So I took this high-tech simulator into a low and middle income country. Why did I do that? I wanted them to have team training, as you see closely. This is Fiji and Samoa. Team training, two different countries. They're never going to work together. But they did it on the simulator. And I teach them everything I would never ever want them to do on a patient. I teach them how to get not into complications with this very expensive high-tech simulator. We have 20 students. I have no chance to have so many patients. So they go home with what they learned, and then of course I want to have a feedback what they do. So the debriefing is over Skype. We talk to each other over Skype. And this is an important word from George Satnayana, original in Spanish. And I think that's important. It's nothing really new. Simulation has been around for a long time. We just have more technical tools. So this changing paradigm is, it's no longer see one, do one, teach one. It's getting proficiency. And arthroscopy and arthroscopic simulation is just one possibility. There's many more, as you heard from Dr. Gloria Salazar. So the background why we introduced simulations in Switzerland is We got very strict working regulations. When I was a trainee, we had the 136-10 rule. 100 hours per week, 36 hours in a row, 10 days in a row. That changed. Now it's 46 hours a week, no more than 5 days in a row, and no more than 10 hours in a row. So we have 3 times more trainees for the same amount of patients. How should I train them? So we had this study, and we had 3 evidences on this study, as you see here. We have to acquire the skills. And of course, the hard fact is, how can we get the skills transferred to reality? If I tell you that my scrub nurse is very happy now because the trainees, they come in to see the first time their patients, they know how to handle those tools. That's a little step, but it's an important step. Of course, we have a lot of simulators available, as you see in the training centers, and we are seeing the emergence of a potential training framework. As Dr. Glario Salazar already said, the framework is important. You're no longer alone. So, as we heard again, I will go back and some learning behavior, which I use very intensively in my teaching. As we heard, 10,000 hours to be the Beatles, 10,000 hours to learn how to play the violin, like Anne-Sophie Mutter. At least 170 arthroscopies to sort of know where the knee is. You know, you're not yet an expert, okay? And what I learn, and I use a lot, is there's 2 curves. There are slow learners and fast learners. Now I have numbers. Before it was the feeling, that's a fast learner, this is a slow learner. Now I have numbers. And now it becomes very tough. I do not want to spoil time on somebody who's too slow a learner. We even kick them out of the program if they're too slow. The exercises on the simulator, they have to do themselves. It's a predefined program I set up. The Basel view of doing arthroscopy. There could be the Mexico City view, the Guadalajara view, the Cancun view. It's up to you. But the Basel view, I can distinguish. You're a slow learner. Why don't you do something else but not orthopedics? It's the first time simulation gets tough on the trainee. So I decide, based on numbers, who I'm going to kick out. If you acquire skills, as we already heard from Dr. Salazar, cognition, integration, and automatization. The 3 skills, that's the same as we've done before. There are 4 key success drivers. This is the first one. Surgeons have a lot of self-esteem. Too much of a self-esteem. And I remember when I used the simulator in the Pacific, at the end of the course, the head of the department came in. Oh, show me, what's that? It's easy. And he was shocked when at the end of his trials, I pushed the button and I had everything recorded. I could go back with him and do a debriefing. All the scratches he had done, all the wrong positions he had, he was very not happy with it. The debriefing, again, is your job. You're going to do the debriefing. You're going to be important. I can train as long as it needs. So the guys in Samoa, from Fiji. They trained until they were happy and until I was happy. No harm to the patient. And I could test enhanced training. I could include some complications, bad view, and so on. So I can sort of adjust the training level, and that's your job. It's not the machine which does it all. You have to turn it on, you have to change. And again, like the pilots, we can go to a very clear, strict program like the pilots. They know how to do. If they fly 100 times from Ciudad de Mexico to Madrid, they go through the checklist every single time, even if they have done it 100 times. So, the change is hard. The change is hard on our old teachers. I remember my old professor said, "What the heck this? It's nothing." Until I brought him and did a test with him and did a debriefing with him. Okay? So, it's hard, and it's important to talk about expenses. Those simulators are not for free. And we have to think about how to get the costs back, how to get the money back to buy simulators. It's maybe not your primary job, but you may help government, agency, foundations, how to pay. So the lack of available funding was one of the issues, and I'm going to show you how we try to do it in Basel. It's all about costs and safety, like in aviation. And safety is the simsalabim word to get the money. Safety. Because your customers, the patients, have a saying. And I show you some papers. We looked at what the patients are wanting. What do the patients say about simulation? Huh? There's several questions. For instance, I enjoyed using the simulator as a patient, and if you look at the numbers here, you see the questions, and when we go back to the questions, let's say for instance questions number 5. I would want my operation to be performed by a surgeon who has trained additionally with a simulator. Q5. Now look at the results. Most of the patients would strongly agree. So why not ask the patient organization to pay for the simulators? They have money. They're willing to do that. There's a double side to the medal, I come to that. But that's a way to ask. Maybe they have some money to give you money for simulations. Okay? And we had some studies done in France. I'm very happy to present those papers. It's not my study, it's from Peter Waldron. They looked at some predictive factors. Is there a difference between female and male? Are dyslexic people better arthroscopists? Yes, they are. It's a positive, predictive factor. If you are dyslexic, you're a better arthroscopist. You will not be able to write your notes properly, but you will do an excellent job. That's proven. Okay? So, again, less time in the OR. And they did a study all over France. Unfortunately, the slides do not project very well. But they had 2 simple exercises done all over the country. And I will show you one. It's not coming. Yeah. So this is a very simple exercise just to get orientation in space. So dyslexic people are very good at that. Excellent. Those exercises, how to orient the tools in space. It's a very simple exercise. It's a virtual space. And when we have the open day at the university, kiddies, the 10-year-old, 12-year-old, they like to do that. They're pretty sleek at that. So you learn how to organize the camera, the tools and everything. So it's a very nice exercise. And then of course, you go to the next when you have a real knee, so the meniscus problem, you learn how to do it in a real knee. So we start first with the simple. That was done in this test in France. Very simple exercise, but there are numbers to it. So they studied a population of 34 women and 3 times more men, which, by the way, shows that still not equality in orthopedic surgery in male and female. And they also looked at, let's say, the time, periscoping. Is there a difference between women and men? They looked at the time, they looked at the path length. So there's some differences. Again, catch the stars, which was one of the exercises, there was a difference. And they also looked if you increase your competence, if you've done more than 50, you see from 232 seconds, you go down to 186, so you're better. So what? Can we transfer that to reality? Yes. Now I'll show you our Basel experience. We start with the Basel experience, then go to the Swiss, then to some European and international experience. Again, the working time reduced to 42 hours a week. At the given time, when I do a presentation like today with you, I only have 1/3 of the trainees in the room. They're on night shift, they're on compensation, they're on meetings, holidays, whatever. And we have 4 hours of training program, which is governed by the government. We have to do structurized training per week. That's one of the points when I go and said to the government, okay, if I have to do that, I need money. And we now are able to track the reading and discussion behavior because I have a software. The clicks and the time they read the books is recorded as well. They don't like it, but I say, if you're using Instagram, Facebook, Google, you're going to be tracked anyway, so I can track you at the university as well. So don't worry. So, right now, that's the rule. They have to finish the program, otherwise they will not touch a patient. It's a very simple rule, and they do that before they go to their teams. In Basel, you're 6 months in a shoulder team, in an elbow team, in a knee team, in a hip team, and so on. So you have to do this program first before you touch a patient. And, which is important now, it's part of the national-wise board exam. If you want to be a specialist, part of the exam will be written, will be anatomy dissections, like surgical dissections, will be oral, will be plastic bone, and will be arthroscopy on the simulator. So simulation became an integral part of the whole training program. And we track progress. Also to say, okay, you're not, like in pilots, if pilots go to Air Force, there may be 400 coming into the training course, at the end there will be 8 left over. So the same happens here. We just tell them, listen, you're not fit for orthopedics. It's tough. So this is part of the program. We have a little software, and the whole system goes all around, from profiling to learning records, reporting what they have, external reporting, curriculum development, training, and simulation. So simulation became part of a complete training program. It's not just simulation, it's part of a global view. So that's what I say. And those kiddies are pretty good at it, okay? Bits and bytes. Now, what's the Swiss experience? Now go beyond Basel. That's very simple. No certification without being tested on a simulator. Very simple. We test at the third year, when you enrolled in a program which is 6 years. At the third year, we have surgical approaches, 25 different approaches on the cadaver, tested. We have a written exam on pediatrics and tumor, and we have the simulator. That's the third year. You have to pass this to go beyond for the second half of your specialty training. You have to pass. Of course, there are other specialties, as we heard from Dr. Salazar. There's an eye. I know from my friend who is a professor of ophthalmology, he does a lot of simulation tests on ophthalmology, like this simulator. They have several simulators with different, tasks. So they are becoming as strict as in orthopedics. You have to do that on a simulator first to go beyond on the patient. What's about other countries? Germany, it's not the government, it's not the hospital, it's the specialty association for arthroscopy, who has set up a little recognition, a little paper. I'm a certified arthroscopist, and part of this certification by this institution, by this foundation, is to pass it on a simulator. So it's not the government, it's not the university, it's not the insurance company, it's the specialty group called AGA. What's in France? France legislation changed with the change of the law of work. So now they're introducing a mandatory safety test, personal training, and simulation gets part of this in France. So here it's the government. It's not the Arthroscopy Association, it's the government. So different countries, different ways how they look at certification. So part of the third residency curriculum is triangulation, and they are starting that 2 years ago. So it's the government in France. What's the Russian Federation? I had the chance to look at this center in Moscow. It's a huge center. They train medical students, nurses, healthcare providers, professionals, red light, blue light, whatever. And it's a huge center, but I had not got the real information. Do you use this as certification like we do in France and Germany and Switzerland? It's a huge center, nothing new to you. You have centers as well. There are a lot of stations for laparoscopy. As you see here. And of course, debriefing and team training is an important part there, like in any. So this is from the disaster room, where you have team training. It's a disaster room, it's very loud. I don't put them on a loudspeaker. It's really music like the Beatles. Anyway, so they have a huge center, but I haven't heard about the certification process over the federation. This is the control room. So what's in Denmark? Denmark says they started to do an accreditation like in Switzerland. And they also say you need to make it mandatory, like we did in Switzerland. It's mandatory, then all of a sudden it comes into rolling. Okay? What's about US? The Arthroscopy Association of the North America has just started a year ago to implement training courses with a very structured curriculum, and they have a different way to teach arthroscopy than the Basel way, which is okay. You just have to know what are the rules. And then you get a certification, a certificate that you passed the training. So the goals are actually to really create this curriculum for each subspecialty, and they go beyond now with procedures. Rotator cuff, meniscal sutures, cruciate ligament reconstructions. All with numbers. So, when I talk about certification, I think the first thing, as I said, for debriefing, you are the important person. So we need to have a certification of you. I think that's important. We need to have certifications for the trainees so they can come to their teachers when they go back to Guadalajara or Cancun. They can say, I passed, I have a certificate, I trained, now let me see the patients. The resident specialists, the government in Switzerland now thinks to recertify orthopedic surgeons at a given time, like 5 years after you finished, to recertify you. There was a big discussion if, let's say, 2 experts will come to your hospital overseeing your work for 2 days, or do we send you to a simulation center? It's a big discussion. If 2 colleagues come to oversee you, that's a lot of stress. When you do surgery with somebody, you know he's gonna give you marks and notes. And then of course the CME certification, recertification is an issue. So I think we have to think about those 4 different ways. And this is the second last slide. Who has the power to give the certificate? I listed a few on this list here. If we have the patient organization paying for the simulator, they will say, okay, I'm accepting you, but I'm not accepting you. Do we want that? Or do we want to keep it in our hands? Shall it be the specialty organization? Shall it be the university or the government? It's debate. It's a lot of debate. I said it's the second last slide. The last one is with a typical Swiss slide. Thank you. Muchas gracias.
Hablamos también aquí en un pequeño espacio para algunas preguntas para el doctor Friederich.
Muss man das so einstellen, dass ich
Por
das...
favor, doctor.
Doctor,
The second, yeah. Forward.
you said about the importance of checklists like pilots and where I come from, we make interventional cardiology, and my teacher has these protocols that are different when we start to make an angioplasty or a valvuloplasty and stuff like that. Do you make, or do you use, I'm sorry about my English, do you use the checklists in the patient in real time on residents or trainees, and what's your experience in the outcomes of that?
Okay. Gracias. I use actually 2 checklists. The first one is before we start. There's one of the running nurse. She reads the checklist. Patient name, date of birth, is it the right or the left leg, you know, all this preoperative checklist. And then at the procedure, I want my trainee to follow in arthroscopy a list of 21 points I set up in my training program for diagnostics.
Right.
He has to follow that.
And the outcomes, is there a difference between using the checklist and not using the checklist on this patient?
It's a very good question, which I really never ever can answer. The only thing I can say, I feel comfortable that they learned the Basel way.
Yeah.
They go out and say, in Basel, I learned it this way. Maybe Harvard is different, or Mexico City will be different.
Okay.
But they come back and say, well, I learned to do it with Dr. Nick. That's the way. But I have no scientific proof. The only thing is, when we look at our records, because we do a record of all our arthroscopies, we have turned on the video from beginning to the end without interruption. So when we do studies, scientific studies, they see everything, you know. We can mark up, yeah, we see the super gutter and so on. So hopefully.
But we feel that it's better.
Yeah. But again, we feel it.
Neither we have
Yep.
evidence of that. Thank
Yeah.
you.
Gracias.
¿Alguna otra pregunta? Por favor, doctor Ruiz.
Thank you, doctor. It was a great lecture. I am a surgeon, and I am conscious that some surgeons can be an obstacle to a set simulation like a training program. I believe that simulation, but for surgeons, it would be more difficult to assess that for clinicians. What recommendation would you give us for implement and efficient programs of simulation in surgeons?
You're absolutely right. As I said in my slide, the change of paradigm. I know that my old professor, who I really adore because I learned a lot, he would say bullshit. But I had to take him to the simulator and said, why don't you give a try? What's wrong when I do a simulation with 21 points I define? I can even take your points and you tell me what you think is important. And then I say, this is Professor X's way to do it. What's wrong? And so slowly, by discussing and by showing that you can do a debriefing, which never happens in real life. You're so busy with surgery, you never have time to do a debriefing. At least in my case. And anesthesia shouts already, go to the next room, the patient is ready. So I think change of the paradigm is the way to go.
¿Tenemos alguna otra pregunta?
Last question, doctor. From your previous slide, who do you think should certificate specialists in medicine? But I would like to know your personal opinion on this and why.
Excuse me, and you, Helen? Please, ma'am.
Lot of simulation. I'm a strong believer in democracy, and I like to keep the independence in my hands, so I think the specialty organizations should do that. And not the government, not the healthcare insurance. It might be the university or the specialty, but not some exterior, not the ones who pay. Because then we will lose our independence. Then an insurance company like Helvetia or Patria in Switzerland will give out the credits and will allow you to do surgery and not allow me. And that's awful. That's awful.
Yeah, that's already happening actually. In the United States, some of the insurance companies are only paying if you are accredited to do a certain procedure. And they come up with some accreditation standards, which are not unreasonable. So I'm sorry, I was just going to say that in the United States it's already happening that the insurance companies are accrediting individuals for getting reimbursed in procedures. And there are some standards that they have to follow, which again are not unreasonable, but you know, it's already happening. And the other thing is that in terms of the checklist and the procedures, for interventional radiology, the Society of Interventional Radiology comes up with documents trying to standardize the procedures. It's not a checklist, it's just a whole document on the indications of the procedures and how it should be done and how it should be followed up on. It's like very generic, but it's very helpful for us to have some understanding.
I showed in my presentation George Santayana, and as you may remember, in 1958 the AO started a way how to treat fractures with special designed plates and screws. And you were not allowed to buy a set of tools without having passed one of the courses. So there was the organization AO who said, yes, you're allowed, no, you're not allowed. At this sort of, it's a gray zone, you know, it's not black-white, it's gray. So who has the right? I think the specialty organization is from all the evils the best.
Yeah, that would be the best.
Yeah.
Thank you, Doctor.
Yeah?
You say sometimes we like surgeons, we have no time to do a debriefing. Is there some validated program for surgical debriefers?
Well, I just tell you the individual way in Basel. As I told you, for 15 years I was head of the department in Bruderholz, that's a teaching institution. Now I'm at the university and my current head of the department, my boss, is a former trainee of me. I trained him some 20 years ago. Then he made a career and he asked me to come to the university for that purpose. So I have a small personal list, but I will assist junior staff and then I go over the case with them. I will stand in the OR with them, help, give them a hand. And we started to number the surgical procedure from 1 to 5. 1 means I lead every single step his hands. Number 5, basically he doesn't need me. And then we number that in debriefing. I say, okay, today was a 3 or a 1.
La simulación es algo sumamente caro y me llamó mucho la atención como el doctor Friederich está pretendiendo involucrar también a las compañías de seguros en la ayuda para la simulación. How and why the companies of insurance are working with you?
I'm always suspicious when a company comes and wants to help me. Because they found a way to reduce their costs. Right now in Switzerland, when you finished your exam, when you're board certified, insurance have to pay. If you bill them, they have to pay. And they try to find a way to reduce the amount of money and reduce the amount of surgeons to pay. And I think they sort of realized, oh, this is a way. So I'm always suspicious.
¿Alguna otra pregunta? Si no es así, Vini, no sé si estamos listos para pasar allá. Entonces agradezcamos al doctor Friederich.